Hello, everyone. Thanks for coming to this session in the evening. And it's always good to have the session on time with the exams. So the choices that were given are fresh in your mind. The questions we've collected are through some of our sources, some of our subscribers. They're very incomplete. Many of them don't have the right choices or the complete choices. Some have no choices. So in this session, like last time, let's make it interactive. I'll finish the list of questions first. There's not a lot of questions. And I'll finish what possibly could have been asked. And I really do request you to send in your memory of what the questions choices were and what you think would be the right answer, the wrong answer. Some questions are controversial. They'll always be controversial. So we'll get into those as well. So without further ado, let's start. So the first question, essentially, there was a question on subarachnoid hemorrhage. Now, subarachnoid hemorrhage is a chapter in itself, and we've covered subarachnoid hemorrhage in our question bank as vascular neurosurgery questions separately. Now, the before we continue, I'll just tell you the most common questions
Disabled.
asked. Excuse me. So sorry. Yes.
Kindly enable the chat. Chats are disabled.
Enable the chat. Okay, okay. I'll just enable that. Just one second. Didn't realize. How do I? I'm so sorry.
Sir, yeah, I'll enable it, sir.
Yeah,
Okay,
okay. You'll have to
Q&A
enable that,
section
right?
as well, where they can drop in the uh,
Sure.
options if possible.
Sure, sure. Great. It's an open question. All right. Should I continue?
Yes, sir, we'll continue.
Okay. Okay. So, like I mentioned, questions on subarachnoid hemorrhage. The basic questions are most commonly how to diagnose subarachnoid hemorrhage. For example, what is the role of a lumbar puncture? What does it look like on the scan? The Fisher's grade, modified Fisher's grade. What causes subarachnoid hemorrhage? For example, a very common question is what the most common cause of SAH is? Traumatic. It's actually traumatic and not aneurysmal, which most people would think. Then there are questions on vasospasm related to subarachnoid hemorrhage, cerebral salt wasting, treatment of subarachnoid hemorrhage due and vasospasm by itself, diagnostic modalities in subarachnoid hemorrhage. Those are the most commonly asked questions and most commonly asked topics. You need to know the radiology as well. They'll put up a CT and they'll tell you that it'll be a difference between an EDH, SDH, and subarachnoid hemorrhage, and it will be very obvious. The most of them ask very obvious CTs where there is a Sylvian SAH, for example, or an anterior interhemispheric subarachnoid hemorrhage. And then they might even ask you which aneurysm is likely ruptured. That is a bit more advanced. It's usually asked in the INI exam. For example, a posterior fossa or a cerebellar hemorrhage would be most likely because of a pica aneurysm, whereas an anterior circulation aneurysm will lead to subarachnoid hemorrhage in the Sylvian fissure or in the anterior interhemispheric area of the basal cisterns. So, if please do start sharing your memory of what question was actually asked on this SH. Let's go to the next one till then. So, a 20-year-old boy developed lower limb paralysis and anal incontinence after 36 hours of a surgical procedure. Most likely, this is due to the two choices we gathered was epidural hematoma, and the second was spinal cord injury during anesthesia. Now, the issue is they have not described what surgery this is. 36 hours of a surgical procedure would most likely be something related to either transplant or it would be something which is a corrective surgery. For example, a spinal scoliosis surgery, which even now in present day doesn't go up to 36 hours. So that is the big issue because epidural hematomas can be present if the patient has been operated for the spine itself. The second thing, epidural hematomas can be due to lumbar spinal anesthesia, but no 36-hour surgery will go on in a spinal anesthesia unless they put in intrathecal catheter, which is rarely done in majority of centers. So it is assumed that it is a surgery under general anesthesia. So the question is really going to be answered on the basis of neurological localization. If it's lower limb paralysis, very specifically mentioned, not upper limb paralysis, we know that the level is somewhere below the C7 T1. And if there is anal incontinence, then it is most likely in the sacral region. See, there can be anal incontinence from even cranial injuries, but even cranial, but they will not be restricted then to just a lower limb paralysis. So anal incontinence with lower limb paralysis most commonly localizes to the cauda equina region. It will localize, in fact, to D12L1, which is the transition zone between the spine and the most common area of this pressure-based pressure-based problems which can affect the thecal sac or the cord. So the answer would likely be spinal cord injury during anesthesia. Although even that is not very common, except that most of us haven't seen 36-hour surgery. So yes, these do happen, these kind of complications. Hypothermia, which we will not see in normal surgeries will be there in the 36-hour procedure. And the localization of it would most likely be at the D12L1 level. Going to the next one. Carpal tunnel block with drug acting for 8 hours. Now, this is more a question of general surgery. Actually, carpal tunnel has been mentioned, so we're putting it under neurosurgery. And this is actually a pharmacology question. And the answer is bupivacaine, hands down. So lignocaine, which we commonly use, we know that bupivacaine is much more long acting. At the end of my spinal surgeries, I often put a bupivacaine epidural block and facetal block so that the patient is pain-free for the next, sometimes 4 to 6 hours. The official is mentioned, half-life is mentioned to be about 90 minutes to 150 minutes. But the effect does last about 4 to 6 hours. Prilocaine, mepivacaine, and lignocaine are all medium-acting local anesthetics. Bupivacaine and a few others are long-acting, but the most commonly used is bupivacaine. We rarely give prilocaine and mepivacaine anyways for our procedures. Prilocaine is sometimes given as an oral spray for oral procedures, and sometimes for example by ENT guys for example if they want to do a vocal nodule and they want to do it fast in an awake patient. So those kind of patients get prilocaine, and even for ophthalmologic procedures. For us, we mainly use lignocaine and bupivacaine in common practice. Bupivacaine is long acting, lignocaine is short acting. So the answer is B. Post lumbar puncture patient develops paraparesis and the causes. The answer is EDH. See, an SAH, if these are the three choices, root injury will not cause paraparesis. Root injury will cause a paresis in the region of the root. So lumbar puncture will be done somewhere along the L4-5 interspace. L5-S1 is very difficult, so most anesthetists don't do L5-S1. They'll do L4-5 or they'll do L3-4. And root injury can happen. The most common complication, actually, if it happens, is SAH, and the second, along with root injury. But root injury is usually rootlets that are injured. And even if a complete root is injured, it will cause, pain. It will cause weakness in the distribution. So if L5 is injured, the patient will not be able to dorsiflex the EHL, will not be able to use the EHL, so the toe will not dorsiflex, and the tibialis anterior will be partially affected. If it's an S1, then definitely there'll be an Achilles tendon palsy and numbness along the same dermatome. Subarachnoid hemorrhage can happen, actually. It's not an uncommon complication. It's not very common, but it's not rare exactly. The reason why subarachnoid hemorrhages happen is because if in lumbar puncture, the anesthetist, or if you're doing it for some other reason, if you pull out a lot of CSF very rapidly, it can lead to the brain having what actually occurs in concussion injuries, which is the brain actually moves around within the CSF space. And many bridging veins can actually burst. Very tiny microvessels can burst. Sometimes the subarachnoid hemorrhage is from some vessel that is in the dura itself, in the inner side of the dura, or from which are traversing along the nerve roots. And those are causing some amount of bleeding within the CSF space of the thecal sac, which then transmits across the entire gamut of the neurological system. But paraparesis will not happen in those cases. In fact, no paresis will happen. Patients normally with post lumbar puncture subarachnoid hemorrhages, they may have seizures, but other than that, they have this tingling and numbness sensation in multiple root values without usually any motor paresis. It's more sensory symptoms, sometimes deeply painful, but very rarely any specific paralysis or paresis. Now, paresis will definitely happen in an extradural hematoma. And this is the complication that will happen maybe once in 10 years in your practice. But when it does happen, you'll just feel really bad because you'll call in the patient for daycare, maybe not even daycare. The patient will come, you'll do an LP, we'll send the patient home for diagnosis, for diagnostic or therapeutic purposes. And the patient will come back in an hour or two with paraparesis, and you'll have to do an urgent scan and remove the EDH urgently. It's one of those complications that happens. For example, you put in everyone has seen this, I'm sure. someone, either some junior or some staff, will put in a Foley's catheter and inflate the bulb inside the urethra. So patient will come for something very small, like a foot surgery, and will go away with a urethral stricture. So it's something like that. And EDH is the one thing we're very bothered about, and the reason why we take very strict consents when it comes to lumbar puncture. CT brain showing bleeding in the midbrain area, EVD is placed. I don't know what the choices would be. Uh, I don't know. Someone has suggested growth hormone excess tumor. I don't think this has anything to do with tumor. Midbrain region bleeds are usually hypertensive. Most common location actually is pons, and pons is the third most common location overall. First being for hypertensive bleeds first being basal ganglia, then being lobar, and then being pons. Uh, Now there's a bleeding in the midbrain, and EVD is placed most likely because of aqueductal stenosis, because the third ventricle communicates with the fourth ventricle through the midbrain. So the question is most likely on the aqueduct. Please definitely let me know in the chat what the actual question and the choices were. Now, about transsphenoidal approach pituitary gland tumor. Now, interestingly, I'm next working on neurosurgery practicals, which are going to be a series of lectures on case-specific neurosurgery, which will also help you in your rounds once you get through your examination. And I have posted both a video of the tumor. In fact, tumor surgery, I've also posted a video in the original description of neuro-oncology. And I have also posted the practical assessment of a patient that has come to you with a pituitary problem, what to do, what not to do, how to prepare, what are the approaches, and how that approach is actually done along with the operative surgery video. So transsphenoid approach, let me know the question that was there from pituitary gland tumors. Most common artery involved in bariatrics is MCA. There's no doubt about it. Both MCC. Now, this is a question that has directly been picked up from books, and I have actually, I think I have this in my in the question bank that I have put up in the Marrow lectures. And now there are both these choices, both MCA and ACA. That's the reason is that the anterior communicating part is shown to be many times showing berry aneurysms. It forms around the circle of Willis, but the choice is MCA. The majority of people have marked MCA. Now, what will happen is some MCQ book will come out, and that MCQ book, just to differentiate itself, will say both MCA and ACA, and they'll quote some paper or something. But it is MCA. MCA has a much higher rate of berry aneurysms than ACA. And when you talk about most common, unless MCA ACA have an equal percentage, then you can't be both MCA and ACA. And MCA is definitely the much larger supplier, and berry aneurysms often form in the smaller branches of the middle cerebral artery, particularly the ones that go towards the thalamus. Cerebellar hemispheric bleed with no mass effect or hydrocephalus with gaze paresis. Again, please let me know the choices. There is no mass effect or hydrocephalus, so it is a lobar bleed, and it is not large enough to cause a mass effect yet, but it has caused gaze paresis. So the gaze paresis can be either likely a cerebellar gaze paresis. It can have a nystagmus component, which is a Bruns nystagmus, or it has not caused. It has gone into the cerebellar peduncle. And the cerebellar peduncle, to the peduncle, it is starting to affect the third, fourth, and sixth nerve nuclei. So it is probably at the upper part of the cerebellum, and the superior peduncle is involved, and it has started putting edema or pressure on the brainstem directly, causing gaze paresis. I'm assuming the questions was based around that somehow. Head injury, post-nasal drip, salty taste, next line of treatment. This is basically CSF rhinorrhea or this is rhinorrhea, sorry. They mentioned post-nasal drip. It could also be otorrhea, actually. So what has happened is this is actually covert CSF leak. They have not mentioned whether it's coming out of the nose or whether it's coming out of the ear, but it is a very common and very important question to ask on your rounds. For a patient of head injury, do you feel that there is any constant sensation of water coming close to your throat, accumulating in your throat, or a salty taste? The next step is acetazolamide. Now, the reason why, I'll just rule out, thankfully, we have 4 options. Antibiotics, literature-wise, have absolutely no role in the stopping or prevention of meningitis in CSF leaks. Now, this has been given in many MCQs, given in many books. That being said, almost all of us are not stupid enough to not start higher antibiotics in a patient with obvious, maybe not the highest antibiotics, not meningitic doses, but at least definitely more than cefuroxime and more than, Augmentin. So we definitely start higher antibiotics, but literature-wise and textbook-wise, there is no role of higher antibiotics in the prevention of meningitis. Definitely does not stop the leak anyways. Drainage, when they mean drainage, you mean lumbar drainage. We place a lumbar catheter and we drain the CSF and keep a low pressure of the CSF. Now, this is not done immediately. We always give a trial of Diamox, which is acetazolamide, 250 mg thrice a day. For the first, at least, now there is no criteria for how long you do it, but general thumb rule is 4 to 5 days you give Diamox. So CSF leaks, majority traumatic CSF leaks spontaneously cease. Then you get acetazolamide, and acetazolamide is given for 4 days. Then we give lumbar drainage. If the acetazolamide doesn't work, then we go for surgery. There are certain instances where we go for immediate surgery. When it is a very high volume leak, when 3D CT scans will show a very large defect, then we may go for immediate surgery, but it's rarely done. Now, the interesting thing with the head injury based CSF leaks is, see, if there is a frontal lobe damage or any other damage to the brain, it'll start swelling. So in these patients, they might be conscious with a small contusion in the brain, but the brain is edematous. That will cover the leak. So they will not have any CSF leak in the immediate post injury period. But after about 3 to 4 days, when especially when you give mannitol, and then the pressure reduces, the CSF leak will open up, and then you'll have it on the 4th or 5th day. They'll start showing a CSF leak. And the treatment for that is to balance it out, reduce the mannitol, give acetazolamide, then later on drain, and then later on surgery. Higher antibiotics, again, no particular role. Gaze paresis seen in among uncal herniation, occipital laceration. Occipital laceration is strange. There will be no gaze paresis. It will be a homonymous hemianopia with macular sparing. That will be the classic pathway. Uncal herniation will lead to a gaze paresis, but by the time uncal herniation is seen, there will be a unilateral third nerve palsy. So it will not exactly be a gaze paresis. It will be a unilateral third nerve palsy. So gaze paresis, when we mention gaze paresis, we mentioned that there is a problem with the processing of the visual pathway, which will happen in brainstem dysfunction, because multiple cranial nerves will be involved. There'll be a bilateral involvement of multiple cranial nerve nuclei, and these are the brainstem dysfunctions is where we get those INO, internuclear ophthalmoplegia, and 1.5 syndrome. So fairly easy question. So this was, I think, part of general surgery. Now the last question, cerebral perfusion blood flow rate. We have done in our MCQ and in multiple discussions everything from cerebral blood flow rate, cerebral perfusion pressure, how to calculate intracranial pressure, how the Lundberg waves of intracranial pressure are there. The cerebral perfusion blood flow rate average is about, now again, this depends on book to book and MCQ to MCQ. Average is 50 ml per 100 grams per minute. White matter is about, so there's a difference between white matter and gray matter. So white matter is about 20 to 30 ml per minute, and gray matter takes up more blood. It's about 80 ml per 70 to 80 ml per 100 grams per minute. So the average for the brain is about 50 ml per 100 grams per minute. Most of these questions, hello. Yeah, so most of these questions will be answered by our, they're fairly simple, straightforward. So if you've taken the lectures, they're very straightforward. Our MCQ bank contained the majority of these anyways, and previous discussions have definitely led to it. Now let's just go to the chat and see what everyone has said. Now, history of Harneet Kurana, thanks. Yeah, history of acute SAH. True is whether it is from mycotic aneurysm most common, males more common, basilar artery most common. So again, I've mentioned, right, most common. So mycotic aneurysm is never most common, because mycotic aneurysm is a bacterially infected aneurysm, and that SAH actually happens in the distal territories of the blood vessels. Mycotic aneurysms are actually seen in those patients who are immunocompromised, drug addicts. So obviously they won't be the most common. Males are more common. That is controversial. I think I've seen more females with SAH. I don't know from experience. Basilar artery most common site? No, basilar artery is not the most common site. Most common MCA followed by ACA. Yes, I think MCA followed by ACA would be the most common. This is not the easiest question to answer. It's controversial again because studies differ, and there are large studies onto the location of the aneurysms. See, now they've mentioned acute SAH, right? So they've not mentioned aneurysm particularly, but again then they've mentioned arteries. So it has to be an aneurysmal bleed, because See, in terms of pathology, traumatic is most common. Second is hypertensive SAH is more common than any aneurysmal SAH. Then comes aneurysmal SAH, for which MCA would be the first, then ACA, then IC aneurysms, then posterior fossa aneurysms, of which basilar would be more common than pica aneurysms. That would be I think, the general trend. There might be some differences in literature, but I think anterior circulation is definitely more common than posterior circulation. Moving on, Sriram Kumar has, thanks for the, sir, I think for spinal anesthesia question, patient is on anticoagulant was mentioned. Okay. So, so then epidural hematoma definitely, then that is you've put in a needle and it's caused an epidural hematoma. That doesn't change the way of analysis anyways. Okay. It appeared like a pineal gland tumor, sir, with dilated third ventricle. Which question was this? What appeared like a pineal gland tumor with dilated third ventricle? I think brainstem, the one where the brain. I'll just go back to the questions. And I think what you mentioned is this. I think this was the question.
In the cerebral ischemia, they mentioned 3 blood flow rates below which ischemia would occur, sir. Less than 20, less than 30, or less than 50.
Oh, okay, that. So that would be less than 20 definitely. So see, the thing is that 20 to 30 would be the average range. Less than 50 is the basic blood flow. Ischemia would occur by around 30, 20 to 30, because white matter would not be perfused. So white matter requires much less. See, even if it's less than 50, gray matter will start to get hypoperfused. Now, again, these kind of questions, no, I'm being very honest with you. If I tell you 20 and next time you mark 20, then someone will say 30 in the examination, but 20 is the best choice. Again, because I mentioned white matter requires 20 ml per 100 grams per minute. So I think 20 would be a very safe choice for definite ischemia. Definitely ischemia will happen below 20. All right. For this question on pineal gland with dilated third ventricle, I think it would be cerebral hemisphere bleed. Not really sure. Okay, if someone can qualify on the chat, what the pineal gland, if even Mayank, we can do it, it'd be nice. Appeared like pineal gland tumor with dilated third ventricle. Okay. Question, Sriram Kumar has mentioned, question to have HIBT stating it as growth, hormone excess tumor, and asked about what is preferred approach for surgery. What is HIBT? I'm not really sure. If you can qualify that, Sriram Kumar, it will be useful. Question gave HIBT, stating it as growth, hormone excess tumor. Must be the pituitary question, right? The pituitary gland tumor, transsphenoidal surgery, hormone excess tumor, and asked about what is the preferred approach for surgery. See, preferred approach surgery will be transsphenoidal. I think what mentioned in the question is actually the answer. What will be the approach for surgery? If it's a hormone excess tumor, it could be most commonly it's acro. See, prolactinoma is the most common, but it is treated medically. Then comes acros, then comes the Cushing's. Cushing's requires sometimes it's so small that it requires a inferior petrosal sinus sampling. So sometimes you can change the approach based on that, but those are very advanced concepts. I don't think they meant to ask that. And preferred approach would actually, the difference would be transcranial versus transnasal approach. That is the only controversy. Within transnasal approach, I don't think anyone in the world is doing other approaches other than transsphenoidal surgery. So if it's a large tumor extending, I did one day before yesterday with an extended skull base approach, but though that is 3 people had said it should be done with transcranially, because if it is the Hardy's grade where the grade is where it's approaching laterally, and NOSP grade is high, which means it's encasing the ICA. Those cases are better done with a transcranial approach to be safer, unless you're very sure what you're going to encounter within. So just qualify HIBT and I'll be able to answer. Pituitary gland tumor had mentioned about patient having diplopia. Okay, if you can mention the question, it would be easier. Patients will come much less with diplopia. Patients normally come with bitemporal hemianopia. Diplopia happens if the patient has had an apoplectic attack. So you will have 2 presentations. I have discussed this very well. It's going to come up maybe in a month or 2. They'll put up the lecture after I make it on, after I do the presentation on practicals. And diplopia will happen most commonly with a apoplexy. Otherwise, pituitary tumors usually grow straightforward in line, and they normally cause bitemporal and severe, perimetric deficits, and the patient will present to you long before they have a diplopia. One option was MCA followed by ACA. Okay, that makes it controversial, and I think MCA followed by ACA would be the right answer for berry aneurysms. I already mentioned this in my talk just now. So it's MCA, then ACA, then anywhere else for berry aneurysms. Gaze paresis is seen in brainstem dysfunction, I think. No? Brainstem, any brainstem lesion will have gaze paresis. So INO, PPRF, we've discussed this in detail in the lectures. What to do was asked as EVD. For this was for which I think what has happened is that I was discussing the question, you're putting it up. Please just qualify the question if possible. Neetu Tommy has asked, option was acetazolamide and wait for 2 to 3 weeks. No, we don't wait for 2 to 3 weeks. We give acetazolamide if the CSF stops. If the patient's symptom stops, then yes, we wait for 2 to 3 weeks. Now they have to qualify whether the symptom has stopped or not. And the day without symptom stopping, without his salty taste and accumulation of fluid stopping, we wait for max 3 to 4 days, and then we put in a drain. So if acetazolamide and again, if they've given only acetazolamide, anyways, first choice would be acetazolamide. And wait would be a difficult to say thing without knowing what has happened after giving the acetazolamide. Antibiotic and observation. No, antibiotic and observation would be. See, again, don't fall for questions with antibiotics, because again, antibiotics will not stop, has no role in prevention of meningitis officially. So antibiotic and observation actually is the thing that is done for 2 to 3 days. So first we do antibiotic and observation. Observation, essentially just observation. That being said, I still think you should mark acetazolamide, because once we have a rhinorrhea, almost everyone will not wait. Once the rhinorrhea or otorrhea is mentioned, we will give acetazolamide. So acetazolamide is still my first choice and most likely the right answer. Surgery, okay. Surgery for, I think this must be surgery for pituitary, which is the question Neetu Tommy has mentioned. I think observation, Arun Gupta said, I think observation was an option instead of drainage. Yeah, we just mentioned that, discussed that before. But I think between anything else, acetazolamide would be my first choice. When is ischemia? Okay, we just mentioned that. We just had a word about that. 20 ml would be my answer. Below what perfusion level ischemia occurs was asked. That is below 20. I have this memory that we've discussed this in my previous questions and in my question bank. So 20, and the choices at that time was even harder. It was not 20, 30, 50. It was 20, 25, 30. It had become even harder. And I think even then we had come up to the conclusion that it would be 20 would be the right thing. Can you show the first two questions? Okay, it must have come late. Nothing. First question was an SAH. We're not sure what the question was. Second question was an epidural hematoma. We just discussed this again after 36 hours of surgery. Patient was on, I think maybe for this question, patient was asked about to be on anticoagulants. They asked about ischemia. One more question was there on gene associated with pilocytic astrocytoma, BRAF, ATRX. I think I mentioned this in my lecture. Very honestly, I'm not really sure. I think the answer would be ATRX from my memory. But I've done an entire section on questions on onco, in which I've mentioned all the genes. And I have also, I think, given a table in that for all the genes associated. It would be ATRX from my memory. Bailey mentioned 20 Bailey mentioned 20. Okay. Bailey mentioned 20. You know what I've done? So there is Sebiston and Bailey. Now I remember where I've done this. Thanks for this thing. I have done a lecture on important neurosurgical points given in general surgical textbooks, because the paper of NEET is often created by general surgeons. So they just pick up directly from Sebiston, Bailey, and Schwartz. So I had gone through what was the neurosurgery portions of each, and I have put in especially these number-based questions. I think you're very right. Bailey had mentioned 20, and this question has been asked before in NEET, and we've discussed this before. Patient with cerebellar hemorrhage with no mass effect, no hydrocephalus, what is the management? Okay, observation. Answer would be observation. This was one of the questions. Okay, B, surgery, C, D. So cerebellar hemorrhage, no mass effect, no hydrocephalus. I must have managed maybe hundreds, and the answer is observation, but very close observation. Because the posterior fossa has a much smaller volume than the supratentorial compartment. So when you see, I'm very sure all of you will get through. Okay, so just we'll be very careful. Just make sure that you don't just leave them apart. They'll suddenly pop it at night. They'll become M2 by morning. Gaze paresis question. Traumatic hydrocephalus was also an option. Won't it also cause gaze paresis, sir? Traumatic hydrocephalus will cause some gaze paresis, but it's very unlikely. See, what happens with hydrocephalus is you will get what? In Congenital, you will get the sunset sign, which is third nerve palsy, very specific third nerve palsy. It's lid palsy along with up gaze palsy. Traumatic hydrocephalus will not specifically cause the gaze paresis or features that which we classically discuss with INO, PPRF, and multiple nuclear involvement. So when you say gaze paresis, remember, a single eye is covered, the patient will be able to look in all directions. But if both eyes are open, in bifocal vision, gaze paresis presents itself. That is why it is called gaze paresis. It happens during gaze. So it is not a fixed paresis. And traumatic hydrocephalus there is nothing to do with single eye or two eyes. And traumatic hydrocephalus is usually before gaze paresis presents itself, the patient will definitely be in a coma. Because by the time gaze paresis comes in any hydrocephalus, patient has already started with raised ICP features, already has vomiting, severe headache, and I think gaze paresis is the last thing we check in a traumatic hydrocephalus. Typo error, sir. Hint. Okay, not sure. That pineal gland tumor question mentioned patient presents with hydrocephalus. What is done was asked. EVD, lumbar puncture. You would never do a lumbar puncture in a patient with intracranial space occupying lesion. It is contraindicated. It will lead to transtentorial herniation. You will lose your patient. It is very basic resident based. I mean, if you do it, they will make sure they make your life miserable. If there is an intracranial space occupying lesion and you've done a lumbar puncture on it, the answer would be between two choices would be EVD. But very honestly, if a patient has presented with the hydrocephalus, and unless it's an absolute emergency, patient has become in front of you M2, then you would do a shunt. You would just do a VP shunt. What we do EVDs for is when we operate the patient, sometimes there is, we're not sure if we can manage the hydrocephalus, or sometimes there is blood accumulation in the cistern. Remember, pineal gland surgery done with the crosses approach, usually in sitting position or in prone or in semi-prone. If you're in the cisterns, so blood accumulated there will settle in the basal cisterns and cause post-operative hydrocephalus. Even the proteins or the changes in the CSF from any tumor surgery in that region will settle down in the basal cisterns, causing hydrocephalus. So for those patients, we place an EVD or an OMAYA for a few days, just so that the patient can tide over that period. Answer would be VP shunt, but if the VP shunt is not mentioned, then EVD would be the answer. Option was acetazolamide given, and if persistent, go for surgery. Okay, this is a different thing. So someone has, I think I've seen this question before. So there's one question I think I've discussed before where it is observation, acetazolamide followed by 2 to 3 weeks, acetazolamide followed by lumbar drainage, acetazolamide followed by surgery. So if the option is acetazolamide and wait 2 to 3 weeks, and acetazolamide followed by lumbar drain, I would choose acetazolamide followed by drainage. The reason is they've not mentioned what the status of the patient is in the 2 to 3 weeks. We can't wait 2 to 3 weeks with an active rhinorrhea. So in that kind of question, you have to assume that the patient still has rhinorrhea and you're waiting 2 to 3 weeks. There is no waiting after the first 4 or 5 days. And if lumbar drain is not mentioned, then the answer would be acetazolamide. And if persists, go for surgery. This is perfect because if lumbar drain is not mentioned, all right. One question that would be the answer. One question was given: clinical features of SH. Patient presented 2 weeks later. Okay, CT was normal. What is done to prove SH? One of the options was lumbar puncture, signs of old bleed. Don't remember other options. So the answer would be lumbar puncture. See, the CT resolves sometimes within 48 hours. Just last week, I think the patient had a very clear sulcal subarachnoid hemorrhage post-traumatic, and it resolved. Now, to prove SAH, the best test is lumbar puncture, and it's not just lumbar puncture with gross examination. It's lumbar puncture. If you have a clean and very neat tap, then you can send it for cells, and especially if it's straw colored, you know from the gross, and if it's not, the cells will show that there is RBC, and that will prove an SAH. That being said, practical knowledge: if you are expecting the patient to have an SAH and you do a lumbar puncture without proving an existent aneurysm, it will burst. When there's a chance that it will burst because of the changes in the CSF pressure. Remember, aneurysms exist in the subarachnoid space. They're outside of the brain parenchyma. where the CSF is, which is why it causes a SAH. So the practical, I'm doing the practical thing. If you have a suspicion of SAH, you will do a angiography. And only when you prove that there is no aneurysm, and you then want to prove if there ever was an SAH, you will do a lumbar puncture. But that will not be there in your options. I don't know why they don't put practicalities in there. They're starting to, some of them are, but then it takes a neurosurgeon to make that question. So the answer would be lumbar puncture. Cerebellar bleed, midline shift plus cerebellar signs positive. Cerebellar bleed, midline shift plus cerebellar signs positive. Cerebellar bleed will not cause midline shift, management asked. So I'm not really sure what this means. I have a feeling there will be something else. See, a midline shift will happen when you have a supratentorial bleed above the cerebellum. Cerebellar bleed will cause direct brainstem compression. So first sign of a cerebellar bleed causing problems would be cerebellar signs. So lobar signs are present. So the patient might have lobar signs, but if there is no edema and there is no compression and no hydrocephalus, then nothing needs to be done. You cannot cure the cerebellar signs by taking out the bleed anyways. The damage is done, it will repair on its own. What cerebral bleeds will cause will be, the next will be the obliteration of the fourth ventricle. So that will cause the hydrocephalus. The next will be direct compression of the brainstem, which will cause bradycardia, hypertension, Cushing's response, cranial nerve palsies, and many other symptoms. And then if you don't catch it by then, the patient is going to become comatose. So let's go cerebellar bleed with midline shift. This is actually a misnomer. Cerebellar bleed with midline shift is not an entity that exists. I mean, you can imagine what a midline shift is, right? It shifts the midline. How will a cerebellar bleed shift the midline? By the time it goes up to the tentorium, it is blocked by the tentorium cerebelli. So that will just lead to this. So tentorium with midline shift, I mean, I'm very confused with what they were asking in the first place. But yes, I'm assuming it requires surgery. Cerebellar shift with midline shift, I'm assuming any midline shift with symptoms will have to have surgery. Cerebellar bleed with other signs was present. Management was asked. So yeah, the answers, the signs can be given, it be easy. Option was observation, EVD, surgery. This option was for what? For cerebellar bleed. So cerebellar bleed with hydrocephalus. So answer would be observation if the patient has no signs, has only cerebellar signs. So I think I can put the question together. So cerebellar bleed had MIS of 3 millimeters, at size of 3 millimeters, cerebellar signs positive, GCS 14 on 15. Observation. Answer would be observation, no doubt. Cerebellar bleed of MIS of 3 millimeters, size of 3 millimeters, very small bleed. Why the GCS would be 14 would be questionable also, because 3 millimeter cerebellar bleed would not cause any problems, which is not a cutaneous sign of spinal dystrophism. Hemangioma, sacrococcygeal dimple, dermal sinus, lipoma. This was one of the questions. Okay. Hemangioma is not a sign of spinal dystrophism. Sacrococcygeal dimple is definitely a sign. Dermal sinus is a sign. Lipoma. The answer is hemangioma. See, hemangioma by itself, understand, hemangioma itself is a congenital problem. So it is not a sign of another congenital problem. It is an independently existing congenital problem by itself. So the answer would be sacrococcygeal dimple, dermal sinus, or lipoma. These are all signs of spinal dystrophism. Capillary hemangioma. No, I have not seen it. So tuft of hair is there, right? So tuft of hair, dermal sinus, even an exuding dermal sinus, not a pulmonary sinus, dermal sinus with repeatedly getting infected, CSF producing dermal sinus. Lipomas are very common. Skin tags on the dermal sinus, those are still present. Skin tags would be less common, but hemangioma or capillary hemangioma is not a sign of spinal dystrophism by itself. It can be a sign that the patient can be syndromic. So they can have a spinal dystrophism, but not in the area of the spinal dystrophism itself. A patient with a hemangioma in the face can also have multiple congenital abnormalities. There are many syndromes that have that, but it is not a sign that there is an underlying spinal dystrophism, which is what they probably mean. All right. And in this question again, cerebellar signs positive, 3 millimeters, observation. If hydrocephalus is mentioned, then EVD. And if the GCS is poorer and there is clear mass effect, answer is surgery. Okay. Any other points, or can we conclude the session? Anyone else needs to ask a question? I'm leaving it open. But it was a good discussion. I'm so glad that you guys participated. Now we can fill up our choices. We understand the questions better. and the recording has been done, so we can put this up in our question bank for next time. Again, I think the majority of questions could have been answered from the lectures. See, at my level, what happens is that you read up so much literature that you don't have a yeah, please go ahead, Arun Gupta. So you end up saying that, this is not the exact thing, but I am talking from when I'm giving you my choices, I'm giving it from past papers which I've seen, and I'm telling you the controversies also, because some person who is a neurosurgeon might say, okay, this is makes no sense. For example, a 3 millimeter cerebral bleed in the cerebellum with 14 on 15 GCS with cerebellar signs actually makes no sense. But anyways, midline shift, for example, cerebellar bleed makes no sense. But there is a question, so we have to answer it. Not a cause of late onset enophthalmos. Can you give me the choices? Options, yeah. Late onset enophthalmos. Orbital fracture. No, it'll be yeah, actually it might be. I'll explain it to you. Give me the other choices. We'll see something more suitable for this answer. If see, I'll discuss orbital fractures. If you can put me till then, you can give the other choices. Extraocular atrophy. Extraocular atrophy. Orbital floor fracture. Orbital floor is the answer. Muscle atrophy, muscles atrophy. See, among all these choices, definitely orbital floor fractures is can cause late onset atrophy. So I'll discuss with you orbital fractures, and I'll discuss with you the choices given. Now, orbital fractures, what happens is, especially in inferior orbital fracture of the inferior orbit, what will happen is initially there'll be edema, so there might be even exophthalmos, but mostly there's just chemosis, a lot of swelling and raccoonine, so you can't observe it. When all this edema settles down, the floor of the orbit, along with the movements of the eye, does not heal. So what happens is that it slowly starts sagging in, and so someday I'll post a picture of this for you. I've operated a post retroorbital cyst where there was exophthalmos, and after the cyst was removed, it turned out to be a cholesteatoma, by the way, a very rare case, cholesteatoma of the orbit. We pushed the eye back in, and it was still, there was so much dead space that it actually sunk into the orbit, because for 2 years the cyst had grown and caused a lot of dead space. So the cyst was removed completely, it went back in, and it sagged into the floor of the orbit, which then required an repair by oculoplastic surgeon. Muscular atrophy, if there is common muscular atrophy, it will not, again, it can cause enophthalmos, but it will be all around. So controversial, muscular atrophy. But why muscular atrophy will only lead to one eye would be difficult to say. It will be bilateral atrophy, and or it will be atrophy in many muscles of the face and the eyes. So everything will shrink. I don't think in clinical practice I've ever seen a case of enophthalmos from unilateral muscular atrophy. Okay, not a cause for late enophthalmos was asked. Not a cause. Not a cause. Okay, edema. Edema is expected anything. Orbital wall collapse, definitely late cause. Fat atrophy, yes. Muscle atrophy. I would say edema. By itself, edema would not be a cause of late enophthalmos. Edema will resolve, it will come back, the eye will come back to its place. So I don't think it will be a cause for enophthalmos. Fat atrophy, muscle atrophy would be more likely to cause late onset enophthalmos. That being said, I have never seen fat atrophy. I've seen. So fat atrophy I've seen from the aspect of a patient who suffered from, for example, a cavernous sinus thrombosis, which has led to long-term reduction in or infarcts of the periorbital tissue. So that has led to fat atrophy and enophthalmos. But it also has other symptoms like bruise. It has symptoms such as significant loss of vision from the retina and retinal edema. So those kind of cases I've seen. By itself, edema would not cause late onset enophthalmos. It will become normal after the edema settles down. Great. Which is not a cause of late onset enophthalmos post trauma. That makes a lot more sense. Okay. So this is the complete question, I think, which is not a cause of late onset enophthalmos post trauma. Edema is not a cause of late onset enophthalmos. That answers the question. All of these can be a cause. Most common is orbital wall collapse. Muscle atrophy and fat atrophy are actually not that common at all after after trauma. All right. Anything else? Right. So I hope you've had informative session. Uh, Again, when it comes to super specialty, nothing is 100%. I wish you guys best of luck for your INI, which is the real test for neurosurgery. There, all of these controversies which I'm talking about will actually come into play, where the answer is not always exact, because the people setting up the exam, and I know some of them are actually very convoluted in their brains. So although last time the paper was the neurosurgery paper was fairly easy, from the general surgery paper was the one that caused all the problems. So I think all the people who got through, I'm in touch with all of them. I think 7 candidates got through in the last INI, and all of them are in touch with me. They've all gone to the really nice institutes, because there were so many seats, and there were 9 seats in the top institutes. Only 7 people qualified, and all of them said that I think it was, and others who didn't qualify, they all said that the lectures were good enough to answer all the questions for INI. Just an update, we're adding to the lectures. I've completed a practical examination of the neurological system, which is a 3 to 4 hour lecture. That's not a lecture, it's a 3 to 4 hour actual demonstration with a dummy patient uh, for all neurological science. And they go according to level. So I've mentioned that this is the MBBS level, this is what is expected in your MCH or DM level, and that is coming up. And also the practical series, where we're talking about practical rounds in common cases in neurosurgery. All the pituitary questions would be answered in that lecture as well. So hope to be in touch with you. Definitely keep posting questions, and it's great learning and knowledge for me as well. And thanks for attending the session, and best of luck for everything.